A very good morning to all of you. I will be presenting partial orbital dacryoadenectomy for refractory epiphora, a way to go. Epiphora can range from mild to severe. In milder form, it can cause irritation, burning sensation, blurring of vision, but in severe cases, it can cause unpleasant swelling, skin maceration, constant burning, sometimes causes ectropy and lot of problems. It can be due to the epiphora, can be due to the obstructive causes and can be due to the functional causes. Literature shows that total number of functional epiphora exceeds the number of epiphora due to the obstruction alone. So in the cases of simple cases like NLDO, we have the option of DCR with very good success rate. But in the cases like traumatic NLDO, proximal cannular obstruction, punctal agenesis, traumatic unsalvageable lacrimal system, we have limited options. One option is to go ahead with the conjunctival DCR. It's a scarlet surgery, good success rate in expert hand, but variable success rate in not the experienced hand, and chances of extrusion of Jones tube is a known complication. It's a time-consuming surgery, needs hospital admission. Other option we have is the lacrimal gland Botox injection. It's a OPD-based procedure. It's a less invasive surgery, but needs repeat injection and it's not cost-effective for the patient. Other option which I will be discussing is the partial orbital dacryoadenectomy. It's a less time-consuming surgery, less invasive daycare procedure, but again it is not suitable for the dry eye patients, should be avoided in children, and long-term success is still unknown. So objective of my study is efficacy and safety of orbital partial dacryoadenectomy in patient with the persistent epiphora. It's a prospective interventional pilot study. We included the patient of punctal agenesis, cannular obstruction, unsalvageable proximal system post-trauma, post-DCT rehabilitation, multiple times failed DCR, and Monk score more than 2. We excluded the patient with the simple NLDO and patient with the dry eye, children's, patient unwilling to go under surgery, and Monk score 2 or less than 2. So in the preoperative assessment, we did the Monk score for the patient, and after that we did the normal slit lamp evaluation was done. Summers test was done to rule out the dry eye, and AIOCMTC was done to measure the tear film height, and NCCT orbit is must before surgery to check for the presence of lacrimal gland, because we have seen the patient with the complete lacrimal gland absence, there is no gland even on the histopath also. So the NCCT orbit is must. Primary study outcome was interpreted as successful outcome at least 2-point improvement in Monk score, qualified success at least 1-point improvement in Monk score with significant improvement reported by the patient. Failure was described as no improvement in Monk score as well as no improvement reported by the patient. I'll just briefly show the this thing. Lateral licorice incision was given, orbicularis was dissected, and septum was opened up. After removing the septum, we see the lacrimal gland, and the lacrimal gland should be differentiated by the orbital fat. Almost 50 to 60% of the gland was removed, fat was placed back, and incision was closed. And we had 6 eyes of 6 patients, 3 were male and 3 were female, and 1 patient has congenital punctal agenesis, and 5 has the proximal cannular obstruction. Average age was 49.3 years, and median follow-up was 7 months. Outcome was Monk score reduced from 4 to 1.8 in the post-op period. Average reduction was 60%. Summers score though reduced from 31.5 to 25, but this was not significant to cause the dry eye. TBUT was very minor changes in TBUT was noted. We can see that pre-op TFS in the very nicely TFS raised tear film height in the pre-op and post-op. This is the post-op of the same patient, so in reduced tear film height. This is the graph of the patient's individual patient. So average TFS reduced from 2.5 to 0.3 mm. In the AIOCMTC also we can see a raised tear film height and reduced tear film height, and average reduced from 1697 micron to 490 micron. None of the patient have developed complication. And our limitations is a pilot study, quantitative analysis of lacrimal gland excision and its correlation with the reduction of Monk score TFS was not done, which we are planning to do now. Sample size is less, so we need a multi-center study. Follow-up duration should be more. So to conclude, partial orbital dacryoadenectomy could be an effective and safe procedure for patients with a refractive epiphora. These are my differences.